Welcome back to the Echo Classroom. Today we have a battle of the muscles, HCM versus HOCM. They may look similar, but only one brings obstruction to the fight. Let's get into it. Today's lecture begins with what I believe is one of the most misunderstood questions in echocardiography. Section 1. The question every cardiac sonographer must answer. What's the difference between hypertrophic cardiomyopathy and hypertrophic obstructive cardiomyopathy? Many students and even some clinicians early in their careers use these terms interchangeably, but they are not the same diagnosis. More importantly, as sonographers, we aren't simply responsible for recognizing thick myocardium. By the end of this lecture, you'll know exactly what separates HCM from HOCM, how to recognize obstruction in echocardiography, and how to evaluate these patients using a systematic approach you can apply both clinically and on your registry examinations. I want to begin with a question. Imagine you're performing an echocardiogram and you observe a patient with severe septal hypertrophy measuring 2.3 centimeters. The ejection fraction is approximately 78%. The ventricle appears small and contracts vigorously. My question is simple. Is this patient suffering from HCM or HOCM? Many students immediately answer HOCM, but here's the problem. At this point, we don't actually know. We know the patient has hypertrophic cardiomyopathy. What we do not yet know is whether that hypertrophy is causing obstruction, and that is the entire purpose of today's lecture. Our goal as sonographers is not simply to identify thick myocardium. Our job is to determine whether that myocardium creates obstruction. We already know this patient has HCM, but one critical question remains. Is there dynamic LVOT obstruction? To answer that, we'll need to evaluate the LVOT, look for SAM, and use Doppler to measure the gradient. Before we learn how obstruction develops, let's make sure we all understand exactly what HCM is. If there's one statement I want you to remember from this lecture, it is this. All HOCM is HCM, but not all HCM is obstructive. Keep that rule in the back of your mind as we work through these patients, because by the end of this lecture, you'll understand exactly why. Remember, HCM describes the disease. Section 2. If hypertrophy is not enough, then what is? I'd like for you to meet our first patient. This patient absolutely has hypertrophic cardiomyopathy. The septum is 2.3 centimeters, which is clearly abnormal. The ventricle is small. The ejection fraction is 75%. So far, everything points towards HCM. But now, look at what we don't see. There's no systolic anterior motion. The LVOT Doppler is relatively unremarkable. The peak gradient is only 12 millimeters of mercury. This patient has hypertrophic cardiomyopathy, but not hypertrophic obstructive cardiomyopathy. And that is an important lesson. Hypertrophy alone is not enough. Something else has to happen before obstruction develops. Now look at these two patients side by side. Their anatomy is remarkably similar, yet only one develops obstruction. So what's the difference? The degree of hypertrophy by itself cannot explain HOCM. We are still missing a critical piece of information. So what are we not looking at? I want you to ignore the septum for just a moment. Instead, look at the mitral valve. Normally, during systole, the mitral valve stays well away from the interventricular septum. But in some patients, the anterior leaflet begins moving towards the septum. Why? We'll answer that in just a moment. For now, simply recognize that something has changed. The anatomy is no longer static. The mitral valve is beginning to enter the outflow tract. And if the mitral valve moves into the LVOT, what do you think happens to blood trying to leave the ventricle? Now we're getting close to the answer. This is one of my favorite concepts in echocardiography because once you understand it, you'll never have to memorize it again. As blood leaves the ventricle, it must pass through an already narrowed outflow tract. As the opening becomes smaller, blood accelerates. As blood accelerates, it influences the mitral valve, drawing it further towards the septum. The outflow tract becomes even narrower. Blood accelerates even more, and a vicious cycle develops. Every beat of the heart reinforces the obstruction. Now we finally understand the difference between HCM and HOCM. HCM describes the abnormal myocardium. HOCM describes the abnormal physiology. And in the next section, we're going to learn exactly how that physiology appears on echocardiography and Doppler. What I want you to take away from this section is that HOCM describes the physiology. Section 3. How does obstruction actually develop? I'd like for you to meet the finding, what is systolic anterior motion, or what we call SAM? Systolic anterior motion occurs when the anterior leaflet of the mitral valve, or the chordae, moves towards the interventricular septum during systole. Normally, the mitral valve closes and stays well away from the outflow tract. In HOCM, however, the leaflet or parts of it is pulled or pushed towards the septum as the ventricle contracts. That movement narrows the pathway through which blood must leave the ventricle. The moment you identify SAM, your next thought should be, how much obstruction is this creating? SAM is not simply an interesting observation, it's often the mechanism responsible for dynamic LVOT obstruction. If the mitral valve moves into the outflow tract, what happens to blood trying to leave the ventricle? Think about placing your thumb over the end of a garden hose. The opening becomes smaller, so the water exits faster. The same principle applies here. As SAM narrows the LVOT, blood is forced through a smaller opening. Velocity increases. As velocity increases, the obstruction becomes even more pronounced. Unlike fixed obstruction, this process changes throughout systole. That's why we call it dynamic obstruction. If the obstruction is dynamic, how should that appear on Doppler? The tracing is one of the most recognizable Doppler patterns in echocardiography. Students often memorize this dagger shape, but I want you to understand why it forms. Early in systole, obstruction is relatively mild because the ventricle has just begun to contract. As systole progresses, the ventricular cavity becomes smaller. SAM becomes more pronounced. The outflow tract narrows further. Blood velocity continues to rise until very late in systole. That progressive increase in velocity provides the classic late peaking dagger-shaped spectral envelope. Once you understand the physiology, you no longer have to memorize the pattern. How is this different from aortic stenosis? This is one of the most important comparisons you'll make in echocardiography. Both conditions can produce high velocities across the LVOT or aortic valve. The difference is in the mechanism. Aortic stenosis is a fixed obstruction caused by a narrowed valve. HOCM is a dynamic obstruction caused by changing anatomy during systole. That's why HOCM produces a dagger-shaped profile, while aortic stenosis produces a broader, more rounded envelope. When you learn to recognize these patterns, your confidence with Doppler interpretation increases dramatically. So how do we prove obstruction objectively? Once we've obtained our continuous wave Doppler tracing, we quantify obstruction by measuring the peak gradient. A peak gradient of 30 millimeters of mercury confirms that obstruction is present. A gradient of 50 millimeters of mercury or greater is generally considered hemodynamically significant and plays an important role in patient management. Always remember that the gradient is only meaningful if you're measuring the correct signal. We will discuss that important pitfall shortly. But what if the resting gradient is normal? I'd like for you to remember this important clinical lesson in HOCM. The absence of obstruction at rest does not exclude obstructive physiology. Some patients develop obstruction only when the preload decreases, or contractility increases. Provocative maneuvers help us recreate those physiologic conditions. Valsalva, standing, and exercising can all reduce ventricular filling, making the cavity smaller and increasing the likelihood of obstruction. That's why a complete HCM examination does not always end with resting Doppler. Now that we understand how obstruction develops and how to recognize it, let's put everything together into a practical echocardiographic workflow you can use every time you scan a patient with suspected HCM. We have reached the end of section 3. Now, let's turn this physiology into a practical scanning approach. Section 4. How should we evaluate a patient with suspected HCM? One of the biggest mistakes students make is reaching for measurements too early. Experienced sonographers don't begin with numbers, they begin with observation. Before placing a single caliper, take a moment to simply study the heart. Ask yourself, is the septum thick? Does the left ventricle appear unusually small? Does the ventricle look hyperdynamic? Does anything immediately make you suspicious for HCM? This first impression often determines how you perform the rest of the examination. The heart usually tells you where to look. You just have to slow down long enough to see it. Now that we have observed the heart, what should we evaluate first? Look carefully for systolic anterior motion. This may be the most important part of the entire examination. If obstruction is present, the mitral valve often tells the story before Doppler does. Watch the anterior leaflet carefully. Does it move towards the septum? Use M mode if necessary. Does it actually touch the septum? If the answer is yes, you've likely identified the mechanism responsible for the obstruction. Once SAM is present, your next step becomes obvious. Now you need to prove obstruction. So how do we prove it? Now we transition from anatomy to physiology. Color Doppler helps us identify turbulence and guides placement of the continuous wave cursor. Continuous wave Doppler then tells us whether the obstruction is dynamic. Finally, we measure the peak gradient. Notice how every step builds on the previous one. We aren't randomly collecting information, we're answering one question at a time. Before we finish the study, there's one more important step. This is one of the easiest mistakes to make. Please remember, if the resting gradient appears normal but your suspicion remains high, don't forget to use provocation. Now, let's finish the study. What does the report actually need to communicate? I've found that if your report clearly answers these 3 questions, you've communicated the most clinically important information. 1. Is hypertrophy present? 2. Is obstruction present? And if obstruction is present, how severe is it? Of course, you'll also document measurements, systolic function, diastolic function, SAM, mitral regurgitation, and gradients, but those details ultimately support these 3 central questions. If the referring physician understands those answers, they'll immediately understand the patient's physiology. We've learned the anatomy, we've understood the physiology, and we've developed a systematic approach to the examination. Now, let's see if we can apply everything we've learned to real patients. You've reached the end of section 4. Here's the key takeaway. A systematic echocardiographic approach transforms suspicion to diagnosis. Successful evaluation of HCM and HOCM answers a series of clinical questions. Your goal is always to determine whether hypertrophy has become dynamic LVOT obstruction. Section 5. Can you recognize HOCM now? Remember, we've covered anatomy, we've discussed physiology, we've learned how obstruction develops. We've built a systematic approach to examination. Now comes the most important part. Can we apply it? Let's see. I want you to approach this patient exactly the way we've discussed throughout this lecture. Start with the anatomy. The septum is clearly thickened. The ventricle is small. The ejection fraction is hyperdynamic. So yes, this patient absolutely has hypertrophic cardiomyopathy. But now ask yourself the second question. Is there evidence of obstruction? There is no systolic anterior motion. There is no significant turbulence. The gradient is only 12 millimeters of mercury. So although this patient has HCM, this patient does not have hypertrophic obstructive cardiomyopathy. Now, let's change just a few findings. Notice how similar this patient looks at first glance. The septum is thick, the ventricle is still hyperdynamic, but now something has changed. SAM is present. The Doppler tracing has become dagger-shaped. The peak velocity is 5 millimeters per second. Using the simplified Bernoulli's equation, that corresponds to a peak gradient of approximately 100 millimeters of mercury. This patient hasn't simply developed more hypertrophy, this patient has developed obstruction. That's the difference. So, let's compare the patients one at a time. What separated the two patients? Not wall thickness, not EF, obstruction. And that brings us back to the rule we started with. So if you remember only one thing from today, all HOCM is HCM, but not all HCM is obstructive. Notice how much more that statement means now than it did at the beginning of this lecture. At first, it was simply a phrase. Now it's a framework. We have reached the end of this lecture, but I want you to remember something. Hypertrophic cardiomyopathy describes the myocardium. HOCM describes the physiology. Echocardiography determines whether hypertrophy has become obstruction. Thank you for joining me in the Echo Classroom. If this lecture helped you and you'd like to support the channel, check out the Roadmap to Cardiac Ultrasound, our step-by-step protocol guide. Just scan the QR code on the screen or use the link below. Until next time, keep learning, keep asking questions, and I'll see you in the next lecture. Here are the references.